So I asked what was some of the things that we should go over today. I was told brachial plexus branches off the axillary artery, understanding of the quadrangular and the triangular spaces, and am I missing something? Is that?
That's what I
That
said. I don't know
sounds
if
pretty
you guys,
perfect to me.
I don't know if you
right.
guys had anything.
Okay.
Those are the ones that I
We can kind of go through that. So first, let's start off with the brachial plexus. I'm going to give you a pretty straightforward way of drawing it out, and this also kind of helps us conceptualize it from a structural point of view. So first thing, if you have paper with you, I would suggest drawing this along with me. So first thing we're going to do here is this, and this. Whereas I have three Y's lying side to side on each other. One of them is inverted in contrast to the other two. So right here off the bat, what we have is we have roots C5, C6, C7, C8, and T1. Okay? And this section before this dotted line, these are all going to be my roots. Okay? These will be my roots. So you can see from here that C5 and C6 are joining together to form one structure. C7 by itself is running as one structure, and then C8 and T1 are joining together to form a third structure. Right? So from here we can now say that these three structures that were formed by the combination of these roots are going to be our trunks. Okay? T-R-K. These are our trunks, right? So this is going to be my superior trunk, my middle trunk, and my inferior trunk right here. Okay? Now, the next part that comes after the trunks is going to be what?
Those like posterior anterior.
Yeah, what are those called?
Branches.
Now, divisions,
Divisions.
divisions, right? So now there's going to be divisions, right? And notice that we've been using some directional names so far for the trunk. So superior trunk, middle trunk, and inferior trunk, because that's the relation that they have to each other, right, on the body. It's the more superior one, this is the more inferior one. Now this is the point of the brachial plexus where it starts to get three-dimensional, right? Where it starts to split into anterior and posterior directions, right? So now we're gonna have divisions, and you know the divisions can be a little confusing for some people. I know for me it was the first time I saw it, but simply put, each trunk is going to split up into an anterior division and a posterior division. Okay, so what we have going on here is superior trunk is going to continue along here as its anterior division, and it's going to give off a posterior division that goes down this way. Okay, and then the middle trunk has an anterior division that goes up this way, and the posterior division continues on over here. Okay, so I'm going to do, so this is posterior division, and then for the inferior trunk, it continues on over here as the anterior division, and then it gives off the posterior division that goes off here, right? And so you see each trunk has one, 2 divisions, middle trunk, 1, 2 divisions, inferior trunk, 1, 2 divisions. And the cool thing about this is that now we can see that all 3 posterior divisions go to the posterior cord, right? All 3 posterior divisions come together to make the posterior cord. And that makes sense, again, right? Because the posterior cord is the most posterior of them all, and I told you that the posterior divisions are traveling in a posterior direction, right? So it makes sense that it's going to make the posterior cord. And the other cords that we have over here are going to be also the lateral cord and the medial cord, right? And this is lateral, posterior, and medial to what structure?
The axillary artery.
Axillary artery, right? So over here in this image, the axillary artery would essentially be sitting right here, directly in front of or directly anterior to this posterior cord. Then you would have the lateral cord on the lateral side of that artery, the medial cord on the medial side of the artery. So this would be as if you're looking at my left brachial plexus. So that was roots, trunks, divisions, cords, and last thing we have is the terminal branches. Okay, the terminal branches, and for the terminal branches, there's going to be 5 of them in total. Over here, I can draw in my famous M. That's the bare skeleton of the brachial plexus at this point. And now we can fill in these terminal branches. So the more lateral of these 3 nerves that makes up the M is going to be which nerve? Most lateral of those. It's the one that pierces through the coracobrachialis, goes through to innervate the rest of the whole anterior arm in terms of, gives it muscular innervation. Right, so this is going to be my musculocutaneous. What's the most medial one of the 3? What's the most medial one of the 3? Ulnar, right? Ulnar. Ulnar is going to be this one. Ulnar nerve. And then in the middle we have the median nerve, right? Okay, so those are the 3 that you see from that M. And then from the posterior cord we have the other 2, which will be, what are they? Axillary and radial. Okay, axillary and radial. And as you study the rest of the upper extremity, you're going to learn in detail where each one of these terminal branches go, right? But the point that we have here is that we have 5 nerves in total, right? Just so happens we have 5 fingers. But 5, that has nothing to do with it. It's just an interesting pattern. But we have 5 terminal branches that all control the upper limb, okay? And grossly speaking, the area where they go, musculocutaneous, right? What area does that innervate in terms of motor innervation? Which muscles? Which compartment of the arm?
It's the skin, right?
Anterior.
So not yet. Anterior compartment of the arm, right? So musculocutaneous is strictly dealing with all the muscles in the anterior compartment of the arm. When I'm talking about the arm, I'm talking about the segment from shoulder to elbow, right? When I say upper limb or upper extremity, I'm talking about this whole thing. But arm is just from shoulder to elbow. And it's only 2 compartments here, anterior compartment and posterior compartment, okay? Anterior compartment is all musculocutaneous, okay? And what about the posterior compartment of the arm, right? You guys haven't gotten there to that yet, but that's where we're going to find our triceps, and that's all radial nerve territory. So whenever you think about the posterior arm, you just think radial nerve. You associate the radial nerve with that. Radial nerve is also the posterior cord, right? So radial nerve is associated a lot with posterior, 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 posterior. Comes off the posterior cord, innervates the muscles in the posterior compartment of the arm, and guess what? It also innervates the muscles in the posterior compartment of the forearm as well. Right? So it literally does the whole entire posterior part of the upper limb, arm and forearm, okay? Arm and forearm, that's the radial nerve, okay? Axillary nerve doesn't do too much. It does the deltoid and teres minor, okay? However, deltoid is an extremely important muscle. Your deltoid is your main abductor, abductor of your upper limb, of your shoulder, I should say, right? So what does abduction look like? What is that? That, right? Yeah. So moving your arm in this direction, right? Going along this coronal plane, right? Lifting it up, okay? So that's what the axillary nerve does, okay? Median nerve you should associate with which compartment of the upper limb? So we said anterior, the forearm, right? We said anterior arm is musculocutaneous. We said posterior arm is radial. Posterior forearm is also radial. Anterior forearm is median. Anterior forearm is median, right? You guys familiar with carpal tunnel syndrome? I'm sure you guys have heard of it before, right? At least in passing, that has to do with compression of your median nerve as it travels through your wrist right here, right? So it literally travels down the anterior aspect of your forearm, okay? So it's susceptible to compression on the distal part of your forearm. That is going to be your median nerve, controls most of the muscles in the anterior compartment of the forearm, and then does the thenar muscles of the hand, right? Thenar muscles are this lump that you see right here by my thumb, okay? Ulnar nerve, what does ulnar nerve do? We pretty much covered all the compartments of the arm and the forearm, right? It's gonna do, so fingers, yes, in the sense that it does the rest of the hand, right? So I said median nerve is gonna do this thenar eminence right here. Ulnar nerve is gonna do the rest of the muscles that are intrinsic to the hand. You have a bunch of small muscles inside of your hand that are controlled by the ulnar nerve. In addition to that, the ulnar nerve, you're gonna find this later when you get to the forearm, contributes to innervation in the forearm. Okay, it's going to innervate one muscle, and it's going to innervate half of another muscle. Okay, very small contribution in the forearm, but nonetheless it does contribute something in the forearm, and it's going to be on this ulnar side, right? It's not going to be over here. It's going to be over here on this medial side. And as you follow the ulnar nerve from this M, it's always going to be the most medial one. It's going to go behind or posterior to the medial epicondyle and travel along the medial aspect of this forearm and enter the hand through something known as Guillen's canal, also on the medial aspect of the hand. Okay? So that's, grossly speaking, the territories where these 5 terminal nerves are going to go. And that's really the reason why we want to know this whole brachial plexus setup. Because when we know this brachial plexus setup, then we can determine from somebody having some sort of spinal nerve injury or maybe having some injury to roots or trunks of the brachial plexus, we can then predict what is going to be the major deficit on the distal part of this brachial plexus, right? So for example, if I have my inferior trunk is severed, which is going to be the most heavily affected nerve out of these 5? Ulnar, right? Ulnar. So C8 and T1 are going to contribute most of the nerve fibers that are going to ulnar. There's going to be some of them that are built to median as well. So median may be slightly affected, but ulnar is going to receive major brunt of that. And likewise, musculocutaneous is going to be severely affected by anything that injures C5 and C6, or the superior trunk. Okay? So that's really the reason why we care about this. Any questions so far about this? All right? The rest of the nerves that come off the cords, right? Because there's all the smaller nerves that come off these cords. So for example, we're going to have from the lateral cord, we have the lateral pectoral nerve, right? From the posterior cord, there's 3 of them that come off. There's going to be the upper subscapular, thoraco, dorsal, and lower subscapular nerves. And then from the medial from the medial cord, there's going to be the medial pectoral, there's going to be the medial brachial cutaneous, and then the medial antebrachial cutaneous that come off that cord. Okay? And then we can fill in C5, C6, and C7 all together combined to make one nerve called the long thoracic nerve. And then coming off the C5 nerve root, we have the suprascapular nerve. Those are the smaller ones that come off the brachial plexus, which innervate some of the muscles around the axilla, around the scapula, the thorax, obviously the pectoral muscles, and stuff like that. Okay? Yes?
So if you were to damage, let's say like you were to damage something in the posterior region of the posterior division, would that damage almost every nerve then? Because it seems like everything kind of goes through there. Besides
Say
the ulnar.
here?
Yeah, like right there.
Like this posterior division of the middle trunk?
Yeah, where everything kind of crosses.
Yeah, so this is mostly going to have contributions from C7, and as it goes along, it's going to go to the posterior cord. The thing is that these things don't travel in a retrograde fashion. They only travel anterograde. So you're going to have C7 nerve roots that go up to the lateral cord, right? You're going to have C8 nerve roots that go up to the posterior cord. But you're not going to have these C7 nerve roots traveling back up this way to then go that way. Okay? No, it just all moves in one anterograde direction, okay, in terms of these divisions. In terms of the motor neurons. So when it comes to these smaller ones, you guys know lateral pectoral and medial pectoral innervate the pectoralis major and minor, right? The upper subscapular, thoracodorsal, lower subscapular. What do these nerves do? Anybody have any idea? What do those nerves do? What does subscapular refer to?
The muscle.
Yeah, directly beneath the scapula. When we say beneath the scapula, we mean the anterior face of the scapula, right? So if I'm looking at the skeleton right here, I'm talking about this face of the scapula that I have my finger on. This is called the subscapular fossa, with inside of which we have a muscle called the subscapularis, right? So the upper and the lower subscapular nerves are innervating the subscapularis. There's also this thoracodorsal. What does thoracodorsal refer to?
Back of your thoracic.
Yeah, it's specifically talking about the latissimus dorsi, all right, latissimus dorsi. So whenever you hear thoracodorsal nerve, there's also a thoracodorsal artery. Those are strictly associated with the latissimus dorsi muscle, okay? This thoracodorsal nerve may also be called the middle subscapular nerve, because they literally come off in order, 1, 2, 3, upper, middle, lower, okay? So you may also hear it referred to as the middle subscapular nerve. But mostly everybody calls it thoracodorsal at this point. Then we look at these right here coming off the medial cord, medial pectoral, medial brachial cutaneous, medial antebrachial cutaneous. What does it mean when I say medial brachial cutaneous? So what is the brachium? What does a brachium refer to? Arm, right? Arm. So again, talking about this segment from shoulder to elbow, right? So medial brachial cutaneous means that it's a nerve that's providing cutaneous innervation or sensation to the medial aspect of the arm. Okay? This may also be called the medial cutaneous nerve of the arm. Medial brachial cutaneous nerve. It's the same thing, just one has a little bit more Latin than the other. Okay? And then medial antebrachial cutaneous is now referring to the medial aspect of the antebrachium, which is your forearm. Okay? Which may also be called the medial cutaneous nerve of the forearm. Okay? And then we have long thoracic nerve. What does long thoracic nerve innervate? It runs straight down the side of the thorax. Serratus anterior, right? Serratus anterior. Now, this is a very common test question in gross anatomy banks. Is they'll give you some scenario of some person who comes in and had a knife fight, and then they have like this lump on their back, right? Or like something protruding on their back. Any idea of what that's referring to?
Wing scapula.
Wing scapula, right? And so what is a wing scapula? What does that mean?
It's like they're stuck back, right?
So it's
They're
not necessarily
pointing
that it's
out.
not
They're like-
necessarily that it's stuck back, but the whole thing is this. So look at the scapula. Look at the position of the scapula right now on this skeleton, right? So the serratus anterior is going to be attaching along the medial border of the scapula, right? But it's going to be on its anterior face, right? So imagine it's attaching to that medial border and is running anteriorly to then attach to these ribs, okay? What that means is that whenever the tone of this muscle, what it does is that it keeps this medial border of the scapula down up against the thorax. Okay, that's what that means. That's just what the natural tone of that muscle does. Now, when you contract that muscle, it will then bring that scapula over and around the thorax. It will protract the scapula. That's the motion that you're doing right now. Any motion, wherever you're reaching forward, is protraction of your scapula, right? So without that muscle there, it'd be more difficult to make that movement. But like I said, the natural tone of it just makes sure that it keeps that medial border down up against the thorax. So if you cut the long thoracic nerve in a knife fight because it's so long and exposed right here, and it can easily be damaged, right? You're going to have injury to this long thoracic nerve, which will then affect your serratus anterior, decrease its tone. Now the scapula, the medial border of the scapula is coming up and off the thorax, okay? However, it may not be that obvious. And so a simple test you can ask somebody to do is just to push up against the wall. So like this, right? If they lean against the wall like this and they have a wing scapula, at that point it'll obviously pop out, okay? It'll obviously pop out. All right, that's the long thoracic nerve. And then we have the suprascapular nerve up here, okay? The suprascapular nerve. The suprascapular nerve is called thusly because it travels, I don't know if you guys can see from that view, but there's a little notch right here on the superior border of the scapula, okay? There's a little notch right here on the superior border of the scapula. That's called the suprascapular notch, okay? there's the suprascapular nerve runs through that notch and innervates a muscle that lies right here in this fossa. That's known as the supraspinous fossa. The name of that muscle is the supraspinatus. Okay? And the supraspinatus is one of 4 muscles that makes up the rotator cuff of the shoulder. You guys will probably learn about that next week or tomorrow. So if the suprascapular nerve is injured, then you're going to have some issues with your rotator cuff. Okay? The way that it produces abduction is going to be impaired. Okay. I'm not going to talk about that now. That's a whole other thing. Okay. That's good for now. Any questions on that? No, straightforward, right? Let's talk about the arteries now. Talk about what I'm doing here. Okay, so if I'm going to talk about the axillary artery, a good way to kind of commit these branches to memory is to realize that you can divide the axillary artery into segments. So first of all, let's talk about what it is before it turns into the axillary artery. Before it turns into the axillary artery, it's traveling directly deep to the clavicle, and at that point we call it the subclavian artery, right? As soon as it passes the border of rib 1, which is literally directly inferior to that clavicle, now at that point it's not called the subclavian anymore, we call it the axillary artery, right? So this is the point where it changes name to axillary artery. We can conceptualize this as
What is CP?
CP is coracoid process. And this dotted line that I just drew, going from coracoid process to ribs 3, 4, and 5, what do you guys think that is? That may be.
Oh, axilla?
Terry.
Not Terry's, coracoid process.
I lied.
Not Peck minor?
Pec minor, yeah, pectoralis minor, okay? So this black dotted line right here that you see is kind of like triangular, going from coracoid process to 3, 4, and 5, that's my pec minor. The reason why I drew that in is because you can use the pectoralis minor, and in fact a lot of people do this, use pectoralis minor as a division to break up the axillary artery into 3 segments, okay? You can break it up into 3 segments. And so the first segment is the part right before the pec minor, second segment is the part directly deep to it, and the third segment is the part directly after the pec minor, okay? And you're going to see why this is a cool thing to do. Okay, so we have those 3 segments of the axillary artery there. Now, there's branches coming off this axillary artery, right? This first part has 1 branch coming off of it. The second part has 2 branches coming off of it. And the third part is going to have 3 branches coming off of it.
Oh, it lines up.
Yeah. Okay. First part has 1 branch. Second part has 2 branches. Third part has 3 branches. Okay, now let's talk about what these branches are. Am I moving too fast, or is it good pace? Good pace. Okay. So first branch, which one's that? It's the highest one. Goes towards the thorax.
Superior thoracic.
Superior thoracic, right? You may see some older books call it the supreme thoracic, but same thing. Superior thoracic artery, right? Superior thoracic artery. Then we have the second part, which has two branches coming off of it. One is a short little trunk that immediately branches off into a bunch of different branches, 4 main branches. Which one's that? Thoracoacromial trunk. So I'm just going to put TA, right? And the TA is going to split off into 4 branches, which are going to be the California Police Department, right? Clavicle, acromion, pectoral, and deltoid branches. Okay. Right, you guys have probably seen in the anatomy they'll have the thoracoacromial trunk is very short, stout trunk, and immediately branches off into a bunch of branches. And you guys a lot of times can obviously see the pectoral branches going into the pectoralis minor, going into the pectoralis major, right? And then the second branch off the second segment is going to be, what do you guys think? So the supreme thoracic, this is going to be, it's going to be lateral thoracic, right? So this is going to be my lateral thoracic right here. Okay. And I should draw these going. Now we have the third part, right? And notice that on this third part, first of all, let's talk about this one. This third part has this big, nice artery right here. This one's called the subscapular artery, okay? The subscapular artery is going to divide into the circumflex scapular and the thoracodorsal arteries. Okay, circumflex scapular and thoracodorsal arteries. And you guys, I think I just talking to your guys on your body, right? How sometimes you'll see off this subscapular. The subscapular can either contain the the lateral thoracic itself coming off of it, or there could be a branch coming off of this subscapular that's known as the lateral thoracic branch of the subscapular, in addition to having its own lateral thoracic. You may see that distribution. Okay, there is slight variation to this. This is the textbook depiction of how these arteries branch. But when you dissect enough cadavers, you'll see that this is not always going to be the case. There may be small variations from this. You can have, for example, the superior thoracic coming off right next to the thoracoacromial, for example, right? But this is just a good way to commit this to memory, right? Part 1 has that 1 branch, part 2 has the 2 branches, part 3 has the 3 branches. Right? And this is what they're going to expect you to know. They're not going to test you in any further detail beyond this. Okay. And then we have these two, the last two of the 3 of the third segment of the axillary artery, right? And notice that these 2 are wrapping around the neck of the humerus. Okay. So we're going to call one of them is traveling anteriorly around the neck of the humerus, and the other one's traveling posteriorly around the neck of the humerus. So we're going to call this one traveling posteriorly around the posterior circumflex humeral artery, okay? And the one traveling anteriorly is going to be the anterior circumflex humeral artery. So you see these words circumflex, circumflex, circumflex popping up over and over and over again. Circumflex just means to wrap around, okay? To wrap around. So the circumflex scapula wraps around the scapula, and these 2 wrap around the neck of the humerus. Okay. gonna erase this circumflex scapular for a little while just so we can see what's gonna happen here. So the axillary artery will continue onward. However, at a certain point, it's going to change name again. It's going to be the same exact structure, but it's going to change name again. Now it's going to be called the brachial artery, right? Or the artery of the arm. That's all that means, the artery of the arm. Question is, where does that happen? That happens at a point here. So there's a muscle that's going to attach right around here. It goes like this. That's going to be our teres major muscle. So as soon as the axillary artery crosses this inferior boundary of the teres major muscle, it has officially left the axillary region. All right? The teres major is the inferior boundary of the axillary region. So once you cross that boundary, you're not in the axilla anymore, and now you're considered brachial artery, not axillary artery anymore. Okay? That's what teres major does. And that's pretty much it. Branches of the axillary artery. Okay? It's the way I recommend to learn it. Any questions about that? All right, let's move on. Spaces. Okay. If we want to talk about the spaces, if we want the spaces to make sense, we need to talk about musculature around the scapula. Okay? So, let's say we're looking at the scapula from the posterior side, right? I told you that there was a muscle lying over here in the supraspinous fossa called the supraspinatus. Right here in the infraspinous fossa, there's the infraspinatus. Directly inferior to that, there's going to be a muscle right here called the teres minor. Okay? Teres minor. 1, 2, and 3, those three muscles plus the subscapularis that's on the anterior side are all going to converge around the head of the humerus to form the rotator cuff. Okay? Now, supraspinatus, infraspinatus, teres minor, there's also going to be a muscle here called teres major. Teres major is not going to wrap around the head of the humerus like that. Teres major is going to come off of this inferior angle of the scapula, but it's going to run anteriorly to then attach to the anterior face of the humerus on something known as the bicipital groove. Okay? So, coming from the same area as the infraspinatus and the teres minor, but not going to the same place. It's going over here. Okay? Now, why am I bringing that up? I'm bringing that up to show you that teres major running this way and teres minor running this way are going to create a little space between them two. Okay? There's going to be a little space created between those two. And let me just draw a little bit of that so you can kind of appreciate it. Spinatus here. That's a little bit bigger than that, but we're teres minor over here. And you're gonna have teres major going this way. Okay. This is us looking at it from the posterior aspect. Okay. All right. The posterior compartment of the arm, I told you, is controlled by the radial nerve, and the muscles there are going to be our triceps brachii. tricep referring to the fact that it has 3 heads. There's going to be a lateral head, a medial head, and a long head. Okay. The long head of the triceps brachii is coming from this posterior compartment. So there's going to be lateral head here, medial head in here, but the long head is going to go like this. Okay? It's attaching to the scapula. Okay? Attaching to the scapula. You guys remember the long head of the biceps brachii? And how the long head of the biceps brachii would run through this bicipital groove over here on the anterior humerus, goes over and then attaches to this thing called the supraglenoid tubercle, right? Called that because it's a little point, a little tubercle superior to the glenoid fossa. Well, this right here, inferior to the glenoid fossa, is known as the infraglenoid tubercle. That's the attachment site for the long head of triceps. Okay, so bicep long head is attaching up here, tricep long head is attaching down here. Okay, now. One, 2, 3, and 4. I've just created the quadrangular space. Okay. So that's teres major, teres minor. This is technically the neck of the humerus. I know here it looks like a little bit of the head, but that's my artistic liberty. It's the neck of the humerus that would be here, and then the long head of the tricep right there on that side. Okay? This is looking at it from the posterior side. Okay? Now, why am I stressing that? Let's say if we look at it, we could also look at this from the anterior side as well, right? We could look at it from the anterior side as well. If we flip this over and we look at it from the anterior side, what we'll see is we got a little glenoid fossa here. So if we're looking at the anterior aspect of the scapula, we'll see the subscapularis staring at us, right? Not the infraspinatus, teres minor, teres major. Now we have the subscapularis muscle, which is one of those 4 muscles that I told you is going over to the head of the humerus to form that rotator cuff. And then we're also going to see, right, because I told you that the teres major is starting on the posterior aspect of this inferior angle, but is traveling anteriorly to then attach to that bicipital groove right there. So we can see the teres major also from this view. Okay. Teres minor is going to be back here. We're not really going to see that. Infraspinatus, not going to see at all. But we can see the subscapularis and the teres major from this view. Also, what we'll see going behind or posterior to this teres major, we'll see that long head of the tricep attaching to that infraglenoid tubercle of the scapula. We'll also see that. And so again, from the anterior side, we can now appreciate the boundary. So I should draw the subscapularis tendon a little bit larger, because it's realistically. Now we could see the four borders of this boundary formed again over here, right? So again, we have the long head of the triceps right here, the teres major over here, the neck of the humerus, but this time the subscapularis. Okay, this time the subscapularis. Okay, so you may hear people talking about the boundaries of the quadrangular space, and you may see some sources use teres minor. Some sources may say subscapularis. They're talking about the same thing, just from a different point of view. Okay? It's the same thing, just a different point of view. So this is what it looks like from the posterior side. This is what it looks like from the anterior side. Now, why do we need that space there? So I tell people all the time, the only reason we care about space's anatomy is because we care about what goes through that space. So, right now, looking at this posterior view of this quadrangular space with the scapula and the humerus, I have these muscles drawn in, right? But there's a muscle here that is not drawn in. There's a muscle that the only way I'd be able to see this is if I was to reflect and cut that muscle away. Okay? So there's a muscle that's covering all this. Any idea what muscle I'm talking about? That's a good guess, but no. Because trapezius is going to be attaching to the scapular spine over here and covering this whole area. But there's a muscle that's covering this whole area. So rhomboids is going to be attaching to this medial border and going that way. Trismus dorsi is going to be coming up this way from down here and going up here. So it's a muscle that's attaching to the scapular spine, the acromion, and the clavicle, and then runs down over the humeral head to attach to something known as the deltoid tuberosity on the humerus. Deltoid tuberosity on the humerus. The deltoid, okay, the deltoid muscle is what is not shown here. Okay, so in reality, if I were to flip the cadaver over, right, and have it lying prone, and I'm looking at this posterior side, what I would see from this view would actually be the deltoid, I'm going to draw it in blue, would be the deltoid muscle covering all of this, like that. Okay? It'd be covering all of that. Now, that means that this quadrangular space is lying deep to that deltoid. Okay? Remember what we said about the deltoid. Who innervates the deltoid? Axillary nerve, right? That one of those 5 terminal branches off the brachial plexus. The axillary nerve is the one that innervates the deltoid. The axillary nerve is over here. It's on the anterior side, right? How's it going to get to that deltoid? It's going to go through that quadrangular space. That's its gateway to that posterior side. And then when it goes through the quadrangular space, it's going to end up right underneath the deltoid. And it's going to go and innervate it. Okay? So that's the significance of the quadrangular space in that regard. Another significance of the quadrangular space, and this is now when it comes to trauma, is that if somebody were to sustain a fracture of the neck of the humerus, right? I know that the neck of the humerus is one of these 4 borders of the quadrangular space. So if somebody were to sustain a fracture of the neck of the humerus, you need to think the axillary nerve may be injured. And if the axillary nerve may be injured, then the deltoid is not going to work. So you would test that on the person. You would ask them to abduct their arm against resistance. And if they can't do it, there's a problem with that axillary nerve. Okay? And that's how you know that this fracture did more than just injure the bone itself. Okay? That's for the delta. There's another structure that goes to the quadrangular space, an artery. We talked about it when we talked about the branches. It was one of those 3 that came off the 3rd segment. One of the posterior humeral circle. Again, it's going to travel posteriorly. How is it going to get to that posterior side of the humerus? It's going to go through this quadrangular space. And look, the neck of the humerus is right there. So as soon as it goes through that quadrangular space, it's going to wrap right around that neck. Okay? So posterior humeral circumflex artery and the axillary nerve go through the quadrangular space, and this is the relationship that it has to all the other structures that are around it. Okay. Okay, and then the other one that we talked about was was talked about with you guys was the triangular space.
Yeah.
Correct? Okay. Let me see if I can throw that in. Yeah, so triangular space, looking at it from the posterior side, would essentially be this right here. Teres minor, teres major, and the long head of triceps. Okay? So there's going to be that little space right there that's created. Again, this is just a portal for structures to go from axilla to the posterior side of the shoulder, or the posterior side of the whole scapular region. Okay? So for that one, there's one artery that travels through it that we care about, which is going to be called the circumflex scapular artery, right? Which is one of those two that come off the subscapular artery. Okay? Circumflex scapular. What that means is that it's going to wrap around. Actually, let me draw it in green. It's going to wrap around the scapula like so. Okay? And it's going to give off a bunch of branches that go across the scapula, right? Now, remember when I told you that there was a suprascapular nerve coming off of root C5 of the brachial plexus? And I told you that the suprascapular nerve is going through the suprascapular notch over here on the scapula. There's also a suprascapular artery, okay, that runs with it, all right? And the suprascapular artery, you guys haven't learned about it because it's not a branch of the axillary, it's a branch off the subclavian. And they're not going there with you guys. You guys will probably talk about that when you get to Unit 3, head and neck. You'll talk about that artery, okay? So there is a suprascapular artery that comes off the subclavian that also goes over the suprascapular notch, but it's going to travel down and it's going to form an anastomosis with this circumflex scapular artery. Anastomosis means a network of arteries that meets together, okay? So the significance of that is that if I were to ligate this artery here, I can still get blood flow to my scapula through the suprascapular artery. If I were to ligate my suprascapular artery, I can still get blood flow through my circumflex scapular artery around my scapula. There's a lot of different anastomotic networks all throughout the body. Surgeons like to know them or need to know them so that they can ligate, they can know which artery can I ligate and not cause ischemia to this part of the body. So this is a situation where I can ligate this and not have to worry about ischemia because I know it's coming from the other side, okay? Yeah, that's it for that. Any questions about this? No? Okay, so that's most of what you guys have been learning so far, right?
Yeah, this is really helpful. Thank you.
Yeah?
This is really helpful.
Perfect. Okay, my pleasure. I'll go home and eat dinner.
Thanks so much.
Yeah, no problem.